So welcome to our first official presentation for our McMaster Midwifery Research Center speaker series of the year. This year, we are planning on offering these talks and presentations on the last Wednesday of every month over the lunch break. So hopefully you can join us for a few more. I'll tell you about the one in November at the end today, so I'll keep you in suspense. My name, I think I know most of you, is Beth Marie Davis. I'm the scientific director of the MMRC, or the McMaster Midwifery Research Center. We are in regular Zoom today, not a webinar format. So if you can ensure your videos and microphones are off, that's helpful. And when we get to the question period of the presentation, you can put things in the chat or you can raise your hand and I can moderate that session. Before we begin today's rounds, I do want to acknowledge that the university, McMaster, and myself are located on the traditional territories of the Mississauga and Haudenosaunee nations, and that's within the lands protected by the Dish with One Spoon Wampum Agreement, and the lands are also directly adjacent to the Haldeman Treaty Territory. And when we offer a land acknowledgement, it's important to also be reflective of our actions so that it goes beyond simply offering these words. And so as a set, reflecting on and fulfilling my responsibilities, and I offer this land acknowledgement in the spirit of that reconciliation. Our speakers today are Esther and Liesbeth. They are both academic midwives and researchers, and they've actually been visiting us for the month of October. So they are in Hamilton at the moment, which is lovely, and they've been able to join us for lots of other things related to midwifery education, midwifery research, all of those good things. And so we're delighted that they're able to join us and provide a talk while they're here. On our advertisements, we talked about the fact that the presentation would focus on the transition to practice, but I think they're going to throw in some extra stuff and background about Dutch midwifery. So I'll let them tell you a bit more about the focus for the talk. I can do some short bios too, so that you know a little bit about them before they begin. So Esther is an assistant professor. Sorry, my thing got covered up. An assistant professor and associate professor.
Assistant.
Yes, okay, lovely. And in the midwifery department of primary care and long-term care at the University Medical Centre in Groningen, and also at the Vrije, is that how you say it? University in Amsterdam Public Health Academy. And Liesbeth is in her very close to being done her PhD. And she also works as a lecturer in the midwifery program. And her research has been focusing on the transition to practice for newly qualified midwives. So that's hopefully a piece that they'll talk about today. And they were at our symposium and talking about it as well. So we're going to kind of build off of those things a bit. And so I think that's it for background. You can share whatever else you would like to about who you are and what you're going to share with us. And we should have time for questions at the end. So we'll save maybe about 10 minutes or so for questions as we go. So thank you again, and I will turn it over to you.
Well, thank you, Beth, and good afternoon, everybody. And welcome to this presentation. So today, together with my colleague, I will be presenting the research program, of which I am the program manager. So Beth already introduced me, but next to my assistant professor task in research, I'm also teaching at the Midwifery Academy Groningen at both bachelor and master levels. So in this talk, I'll be talking mostly about women, but of course I don't want to exclude anyone who identifies differently. So next to me, you can see Liesbeth. She's an educational scientist as well. And she is also a teacher at the Bachelor of Midwifery and the Master of Midwifery program. So before I talk about my own research program, I would like to tell you a little more about our organization and the research my colleagues are doing. Perhaps you will see some opportunities for collaboration. In addition, I will give some insights into the midwifery care system in the Netherlands. Does this work, Beth? Is there a change of slide?
Yes, it did change. It looks
great. Great. Thanks. So our department has two locations, one in Amsterdam and one in Groningen. In Groningen, we are affiliated with the University Medical Centre Groningen and the Midwifery Academy Groningen. So in Amsterdam, we are affiliated with the UMC, that's the University Medical Centre Amsterdam, and the Midwifery Academy Amsterdam. Of course, both locations are connected to each other. This gives us great opportunities to do research together, which in turn can be used for local applications. Our staff consists of 5 senior researchers, of whom Ank de Jonge, or in Dutch Ank de Jonge, is our full professor in midwifery. In addition, Corine Verhoeven and Jens Hendriks work in Amsterdam, and Lilian Peters and I work in Groningen. I will show you their research programs on the next slides. Let's start with Jens. He works in Amsterdam, and his central feature of research is to understand the factors related to positive peripartum mental health and to be able to reduce peripartum psychological distress. My other colleague, Corine Verhoeven. She is an associate professor in the Netherlands and a professor in midwifery within the UK at the University of Nottingham. Her program focuses on the evaluation of maternity and/or midwifery care, and more specifically on optimizing physiological labor and birth. Then Ank. Ank de Jonge is our full professor in Amsterdam and Groningen and head of the department in Amsterdam. Her main topic is regarding watchful attendance. Maybe you've heard about it. Watchful attendance denotes being very present and connected to the unfolding event. The term expresses a combination of continuous support, clinical assessment, and responsiveness. Ank states that not giving watchful attendance should be as unacceptable as not providing an epidural anesthesia at a woman's request. Then my colleague Lilian. She's an assistant professor in Groningen, and her focus is on women's health epidemiology, especially about events during pregnancy and birth and its impact on maternal and children's health outcomes. Furthermore, she investigates pregnancy and birth experiences. So if you want to contact one of my colleagues, I can provide you the email addresses. So that's me. So this is my research program. It focuses on the organization of midwifery and maternity care in the Netherlands. Specifically, we pay attention to the needs of women in vulnerable situations. Additionally, we prioritize the well-being of student midwives and the sustainability of the midwifery workforce. Before I go further into the content of my research program, I would like to explain a little bit more about the organization of midwifery care in the Netherlands. Some knowledge about the context of Dutch midwifery will help you to understand the findings of our studies. After that, I will tell you about our research regarding pregnant women in vulnerable situations. Liesbeth will tell you about our research regarding the well-being of midwives. Some facts. We have more than 170,000 births per year, which is an average of 1.62 babies per woman. Women in the Netherlands give birth to their first child at an average age of 30.3 years. So we are a very dense country, as you can see, compared to Canada. Midwifery in the Netherlands. Community midwives take care of normal pregnancies and birth and postpartum periods. This means that our scope of practice is strictly aligned with this premise. For instance, a difference I noted with your scope of practice: community midwives do not care for women who need an induction of labor. These women are referred to the obstetrician or hospital-based midwife. If problems arise, pregnant women are referred to hospital. Hospital midwives provide this care. 90% of all midwives is a community midwife and 10% a hospital-based midwife. 85% of pregnant women start care with a midwife. Community midwives in the Netherlands often organize their practice in small independent practices. This often means an association of midwives who are all practice owners, with an average of about 4 practice owners. Sometimes they employ other midwives and others work as locums. I wanted to show you this in an example of the care trajectories. So this is for first-time pregnant persons, women. Almost 90% of them start care with a midwife. Within pregnancy, 47% will be referred to secondary care. And during birth, 33% will be referred to secondary care. 15% of women deliver at home in the Netherlands. Furthermore, we have a unique feature, I think. Those are our maternity care assistants. Maternity care assistants provide care for mother and child during childbirth and the postpartum period. They follow an educational program of at least 18 months. An intake to assess the nature and extent of maternity care and the safety of the home situation takes place well before the birth. The maternity care assistant assists the midwife or general practitioner with births at home, in a birth center or outpatient clinic, and in some situations in the hospital. Maternity care assistance is provided to all women at home, regardless of where they gave birth. During the first week after the birth, the midwife supervises this care. The maternity care assistant looks after mother and baby, provides information, answers questions, and identifies any problems. If necessary, she alerts the midwife or GP, who are responsible for the medical care of mother and baby. So let's move on to another subject of this presentation: improving the access to care of women in maternity care. Our initial focus is on the Dutch healthcare system. Where can we contribute to changes and how can we implement them? Historically, we worked from a medical perspective in which physical complaints and symptoms were the starting point. However, in 2008, alarming figures were published indicating relatively high perinatal mortality and morbidity in the Netherlands. This was a concerning finding, especially for women in vulnerable situations who experienced even worse outcomes. As a result, we started focusing on improving access to care for this group, and incorporating psychosocial factors into risk selection became important. We also discovered that in the northern part of the Netherlands, in our region, the focus is mainly on women without a migration background who have been living in poverty for generations. In other parts of the Netherlands, the focus is on women with different backgrounds. In my research program, we focus on prenatal care, perinatal care, and postpartum care, as we know that the period up to 1 year postpartum is a critical time for maternal health. It is especially challenging for women in vulnerable situations to seek and receive appropriate care. To better understand the concept of access to care, we rely on the conceptual model developed by Liesbeth in 2013. This model provides insights into the barriers to access from both the perspective of the healthcare system and the user, allowing us to gather knowledge about the entire concept through specific studies. The model can be used to design studies and analyze research data, both a priori and posteriori. In my research program, we study both the demand and supply side of access to care for women in vulnerable situations. Over the past few years, we have published quite a lot of studies and are currently working on 3 projects to improve access to care. Based on the results of our research, I would like to present 5 conclusions that capture the essence of it all. The first is, stigmatization is a problem for both women and healthcare providers, which hinders the access to care. One of the perspectives of a healthcare provider was the following: people who don't want it, you can talk to them as much as you want, but it's not going to happen. So that's why I don't think it's worth investing my time and energy in. and from the perspective of a pregnant person. And that's when the rage came bubbling up. Like, it's so unfair that I'm being placed in a box and treated like this based on my past. I come here for help and it feels like I'm really just torn down. To address these issues in communication between midwives and women, we have developed a training for healthcare providers to help them better connect with women in vulnerable situations. Secondly, continuity of care is important for women in vulnerable positions. They have to deal with lots of care professionals, especially when being vulnerable. This can lead to withdrawal of care. A pregnant woman told us, and you're being sent home with the comment, hey, if you're not doing well, you should call again. You basically have to repeat your story constantly. Constantly. Nothing is written down and no issues are put through to others. You're constantly trapped in that story and you're constantly explaining yourself. By conducting action research, we are currently examining how to improve continuity of care. Number 3, sufficient interventions for vulnerable populations have been developed. In the 3 northern provinces in the Netherlands, there are already 47 interventions available. That would be enough. However, implementation isn't well enough. Our studies showed that the degree of implementation is still moderate. More and more, we are focusing on implementation research, which is culturally appropriate for our own region. Let's go on to the 4th conclusion. Identifying women in vulnerable situations is challenging. Healthcare providers often fail to recognize these women, or they may be hesitant to discuss their situations. That's why we are aiming with the Jong project and the Together for Health project to improve this by performing participatory action research. So we also include women in our research. When identified, complex collaborations between social services and maternity care providers are required in order to tailor care to the needs of women. The slide shows an example of all collaborations between health and social care professionals in the city of Groningen. This picture is the result of a social network analysis we conducted last spring. Based on this picture, we are working with professionals to improve collaboration. And as you can see, many networks are formed. In providing high-quality care, the well-being of midwives is crucial. Research shows that the well-being of health professionals has an impact on their own health as well as the quality of care they provide. When health professionals experience burnout symptoms, there is a risk of reduced performance and errors. Additionally, there is an increased risk of leaving the profession, which could result in a loss of accumulated experience and knowledge. Therefore, we also conduct research on the well-being of midwives. Liesbeth will now take over and discuss this further. Liesbeth, it's your turn. Let's change positions.
Yeah, we have to change position. Thank you, Esther. Okay. And good afternoon to you all. I'm glad that I may present a bit about our research on Dutch midwives' well-being. I did several studies about this topic for my PhD thesis, which I will defend next month. My thesis is about midwives' occupational well-being, in specific, the differences between newly qualified and experienced midwives. Furthermore, I did research on the transition into practice experiences of NQMs, newly qualified midwives, and which components of support are important and applicable in maternity care in the Netherlands. However, today I will present to you our results regarding the occupational well-being of Dutch midwives and the differences and similarities between newly qualified and experienced midwives. This is my PhD thesis, so if you are interested, you can ask for a copy. It would be nice. First, about the definition of occupational well-being, which is a broad construct that includes both individual and organizational factors that interact and lead to the well-being of professionals or employees. I will also show you the theoretical model which we use for the underlying constructs of well-being. We used the job demands resources model in our studies. This model is broadly used for different occupations and professions and is a heuristic model, which means that different job demands and resources does apply for different occupations. So each occupation can have different job demands and resources. In this model, this well-being is not only defined as burnout, but also has a positive side, work engagement. That's the middle part. Work engagement is another construct which is different from, for instance, job satisfaction. On the upper left side of the model, you can see job resources. Job resources are helping the professional in the work and leads to work engagement and to outcomes such as better performance and reasons to stay in a job. Job resources such as working with the women or support from colleagues can lead to more work engagement. And work engagement refers to a positive, effective, motivational state of high energy combined with high levels of dedication and a strong focus on the work. When we look at the second rule on the slide, we look at the health impairment process. Job demands, such as high workload or physical strain, may lead to exhaustion and cynicism. This can lead to burnout symptoms and negative outcomes such as sickness or intentions to leave the job and actual turnover. In the center of the model, we look at personal resources. These resources, such as optimism, self-efficacy, resilience, help the professional in their work and contributes to more work engagement or, when lacking, to more burnout symptoms. In the next slide, I will show you several outcomes on the different parts of this model. I need to have some breath. I'm over my breath. Okay. But first, the rationale of our studies. Midwives in the Netherlands showed worrying figures about their intentions to leave the job. It is known that intentions to leave is an important variable of the reasons to actually leave the profession. National figures show that midwives with intentions to leave the job within 5, 10 or 15 years after graduation leave. 6% after 5 years, 20% after 10 years, and 40% after 15 years in practice. So in the end, we are losing almost half of the workforce of midwives within 15 years. So we have conducted a study among midwives' well-being in the Netherlands in 2019 and repeated this study in 2023, in this year. In our previous study on Dutch midwives' well-being, we added not only burnout symptoms with negative well-being, but also work engagement to the model. What we saw in 2019 may not be surprisingly that midwives were highly engaged into their work. 38% almost of the whole population in the study was highly engaged in their work. We had a sample of 896 midwives. It's about a quarter of the whole population. Newly qualified midwives, however, showed almost 50% of high work engagement. And experienced midwives on the right side of this slide showed almost 35% of high work engagement. On burnout symptoms, which figures show, of our findings show, that about 7% of our midwives suffered from burnout, which is a low figure compared to international findings. 9% of the NQMs, dus the newly qualified midwives, and 7% of the experienced midwives showed burnout symptoms. We used another burnout scale in our studies, which is widely used in the Netherlands, but seemed less comparable with international outcomes. Oh, and what I always also want to tell you is the 7% of burnout symptoms might be promising, but we also, one part of measuring burnout symptoms was the measurement of exhaustion, and almost 20% of midwives suffered from emotional exhaustion. So that was less promising. As you can see, I'm sorry. In the 2023 study, which we did last year, we had a population of 809 Dutch community midwives. And about 40% scored high on work engagement, that was similar with our previous study. And 30% of the midwives show personal related burnout, 16% work related burnout, and 3% client related burnout symptoms. So the figures seemed higher, but it's almost, it's hard to combine these figures from 2019 and 2023 because of the differences in scales we used. The data, as you can see, determinants of well-being we measured are the most important job resources for midwives, our passion for midwifery, relationship with colleagues, and the variety of the job. This may not be surprising due to the work of community-based midwives, self-employed, working with the pregnant persons. Job demands, which were significant, were being on call and having a work-home conflict. There seem to be some barriers to combine work and personal life in the Dutch midwifery profession. We also conducted a mixed method study on intentions to leave and actual turnover on midwives in the Netherlands. As you can see in a theoretical model, we studied the line from job demands to burnout to intentions to leave and actual turnover. We defined intentions to leave as the probability of leaving the profession, as it is an important indicator of actual turnover. In this study, we also conducted in 2019 and 2023. This year, we found that 52% of Dutch community midwives intended to leave the profession. This percentage has increased compared to the figures 4 years ago. Research in Canada shows that 67% of the midwives had intentions to leave the job. In Canada, the main reasons they gave for the intentions to leave was the negative impact of an on-call schedule on personal life. So the demands of the job as a reason for leaving might have similarities between the Netherlands and Canada. This is one of the reasons we are here, to have some conversations with you. So we might discuss this a little bit later. This year, we also included intentions to stay in our studies, as are inspired by your fellow colleague researchers in Canada. We defined intentions to stay as an individual's willingness to remain in a career for a long time. We adopted the same definitions as your colleagues used. As our findings shows, fortunately, 72% of our midwives had intentions to stay in the job. As important reasons were the passion for midwifery and flexibility in working hours, being important job resources. Compared to midwives in your country, the majority of the midwives in Canada had intentions to stay in a job. And the reasons they mentioned were different in our two countries. In Canada, an important reason was a match between actual and preferred employment and its financial rewards. These were job resources which were not mentioned in the Netherlands. So maybe we can discuss, this is the end of our presentation, what we wanted to tell you today. And maybe it's now time for some discussion.
Thank you. That's great. Yes, I think we do have time for discussion, and we have, a group of, I think, very engaged, very interested folks with us today. So we can even turn cameras on if you want, put your hand up if you have something you'd like to share, and we can have a little bit of a dialogue, because I think there's so many things in what you've mentioned that ring true for our setting as well. So yes, anybody want to start us off with some questions? Everyone's going to be shy now.
Yeah, no worries.
I think you've touched on a lot of things that are, certainly front of mind in the research that is happening in Ontario, looking at sustainability and burnout and, intention to leave and all of the factors that play into that. And that model that you showed, I think, is a really nice way of thinking about that, the resources. And yeah, I think that's a helpful framework. So it'd be interesting to kind of think about it with that lens for us. I see Anne's got her camera on, so maybe Anne, you want to weigh in with a question?
Hi, I am on my phone and I apologize. I'm in leave very shortly, but I just wanted to thank you both for your presentation. I agree with Beth's comment around the urgency of this kind of research, the importance of this kind of research in both of our countries. I do agree that with what you've said, Liesbeth, that this is definitely a concern in both countries. And I found it interesting the difference with the instrument that you used in your two studies. So it'd be quite important for us to talk about the kind of instrument that's most appropriate for in the Canadian context, if we're going to look at similar outcomes. But you've prompted some really interesting thoughts in my head, and I just wanted to take a quick moment and thank you for that.
Thank you.
Thank you. Now, I think we added in the well-being studies, there are several well-being studies and also meta-analysis about midwives' well-being, and I think we added a lot with the work engagement, with the positive well-being, because you can see these are two different processes next to each other. So a midwife can be both exhausted and engaged. And I think the work engagement helps most of the midwives to stay in the job. And when we are aware of the reasons to stay in the job and the reasons to leave the job, we can do something about it, or might influence these factors whenever possible.
Yeah. Exactly.
Yes, and I know you're working on some research as well related to professional identity, and I think that will be a really interesting piece in terms of what contributes to that engagement, right? So where does that come from? What is it about, being a midwife or seeing yourself as a midwife that keeps people engaged, even when the other demands start to, become heavy and challenging?
Yeah. So it was also interesting because the client-related burnout figures are very, very low. So most midwives, and we saw it also in our reasons to leave midwifery, so midwives who already had left the profession, they were also not, I have nobody spoken about client-related factors contributing to leaving the job. So the problem isn't in the pregnant persons, but it's most of the time in the organization and collaboration part of the job.
Right.
Yeah, and what you were saying, Beth, we are just identifying at this moment. We had some interviews with Dutch midwives about the professional values, because these values we have to keep. On the other hand, sometimes the midwifery values are so strict and so highly valued that midwives can't meet these standards anymore, and then they just drop out. So we have to make them explicit again. I think we all know them, but still we don't talk about it. So we want to try with our research to make that more clear. But we also want to do that for the Canadian midwife. So we already are working with you, Beth, about that, and hopefully we will write about it as well, so we can compare it. Like maybe we have the same values, or it's shifting a bit, but those values can be important when you want to change something in the system, that you can take along those values in your backpack and say, okay, these values have to be kept. Otherwise, our profession will go away, or we'll do something like nurses can, or we will be some kind of doctors. That's not why we are midwives. So that's why we are investigating that now. Yeah.
Yeah, and I think it's really interesting because as you said, the values, making them explicit, I think is important. Examining how they may need to even change from the traditional values that may have, previously informed the profession. But then, as you said, that gap between expectations of the values and the reality of the values may also be challenging. And as you said, I can see how that would sometimes contribute to people feeling like, well, maybe this profession isn't for me if I can't meet these values or these expectations.
Exactly. Yeah. We hear that in our interviews. They are having problems with that. The Dutch midwives. They say, okay, I have to be like this, but I can't do it. Yeah, it's too hard. Yeah.
And will you look at factors like age and years in practice and how that impacts some of those?
Yes, we'll ask it, but it's qualitative research, so it's not an association. But we try to sample. We recruit our participants like with that factor in mind, with those kind of factors in mind. Yeah.
Yeah, and some of them were talking about, especially the midwives with young children. You want to be to work in a continuity of care model, and that's what they believe in. But it's also hard to combine these two factors. Right. So it's a challenge to to make it work,
to keep up all the values you want to preserve, I think. Yeah.
Yeah, no, that's great. Well, we will look forward to hearing that. And as you said, we're going to do some data collection in Canada too, so people can stay tuned for that once we get our ethics approval.
Yeah.
I see Stephen and Claire have their video on. So Stephen was first, and we can do a question from there, and then we'll go to Claire.
Well, hello. Thank you so much, Esther and Liesbeth, for your presentation. It's nice to see you both again, even though we're on a screen, but it's all good. Yeah, really interesting. And I this is more of a comment followed by a quick question, I suppose. Especially like Liesbeth, as you were talking about like the well-being and burnout rates among midwives, and also about like some of the client factors that could impact this. It really made me think about the role that I had before coming into doing midwifery research, which was youth and family support. And I was a service provider. And one of the things that I noticed very quickly in that role was that one, I was in a position as sort of a first point of contact for a lot of people, or maybe even a last point of contact for them, where the work I was doing was filling a lot of gaps in the existing service map. And part of that came with the kind of the responsibility of knowing that if I couldn't provide a service, or if I burned out and couldn't meet the need, that no one was going to meet the need. And I'm really, I mean, I'm very new to midwifery, but I'm wondering from both of you if that's something that maybe that midwives experience as, you know, as a person that's in a role that's providing a holistic continuum of care, that I could really see, you know, being in a position that addresses those gaps in healthcare. But because of that, and because of maybe the factors of a lot of clients, like if they're living precariously, if they have all these other sort of factors in their lives that are impacting their well-being, like is that a tension that a lot of midwives experience, with trying to kind of support people that might be living, you know, in precarious ways, or struggling in the way that they're struggling? I hope that makes
Yes,
sense.
it makes sense. That is kind of conflicting, really, because I was telling about the care for vulnerable populations. We didn't have that in our eyesight, like for many years we just did the medical things. And now this is social midwifery comes along, and we have to integrate it in our just regular care. That's very hard, and still women midwives want to be there for women. That's also a very important value. So that makes them feel a bit in distress. So how do I take care for all these problems these women have, and I don't know how to refer them, or I don't know the other practitioner who can help me. So that's kind of a problem. First, we weren't aware of the problem, so it was okay. But now we are aware that the relation between vulnerability and outcomes is obvious. So now we have to do something with it, and that's a problem. So that's also a conflicting thing, a factor in the Netherlands. And some midwives do everything, but they do it in their own time because they aren't paid for that. And others say, I don't want to do it. I don't want it. So maybe they do this bit. Yeah.
Yeah, in our interviews, we heard some case-loading midwives who had less persons in care, so they can choose how many pregnant persons they want to take care of. The costs of care. And they said, I want to take care in a way that I wanted to take care for. So I earn less, but I'm very engaged in my work, and so I can take time if I want to for the
but still we see that caseload practices, like the women, the midwives who take care of a few women per month, the women who go to those kind of practices are most of the time highly educated women. So the women who are in vulnerable positions go to the regular practice, like the normal caseloads. And our caseload is quite high. For a normal income, you have to have 105 full courses per year as a midwife. So you can imagine if there are four midwives working in a practice, then they have now like 400 births per year. So that's pretty high. So then also you can see how many time they have. They have per prenatal consults for in average 15 minutes to talk about everything. So if a woman has problems, then it's quite a problem for the midwife because she doesn't have the time. And that makes already, again, a conflicting value in her. Yeah.
Sort of where a midwife can... Yeah. Oh, sorry.
No, I was selling. I make a quick solution. We have to lower the caseload, so.
But keep the pay.
Yeah, just that you could quickly become a social worker as well as a
Yeah,
midwife in
exactly. And that's
scenarios, I
not,
guess is,
that's
yeah.
not possible. No,
Mhm.
exactly.
Well, thank you so much. That was really a really
You're
great learning
welcome.
experience.
Yeah.
Thanks, Stephen, for the question. And maybe we'll go to Claire, your question as well.
My question kind of got changed a little bit based on that answer and that question was just proposed. So mine, I'm kind of twisting it a little bit more. And you may not have an answer for this, but you know, some of the work that I'm doing or involved in is talking about expansion of midwifery scope in order to better meet the needs of the public. But also, I think the counter side is also meeting the needs of midwives, what they want to actually do, and which would bring the balance to their work life. And so I'm curious if in any of your studies or even in your country, if there are, because you alluded to this, there are other roles that of other healthcare workers that support the role of midwives. And so do you think that there could be another or support role that could offshoot some of the work that midwives are doing in order to continue to meet all those needs, continue to expand scope, or your scope. Anyway, I'm just wondering, you know, midwives can't do it all because there's just so much. So maybe that's a matter of breaking it off into different roles. I don't know.
Like some
Anyway,
different, like a different, how do you say it? I know it in Dutch, of course. Like making special roles for midwives. Yeah, we are not there yet. We have some specific roles like ultrasound midwives. They make the ultrasounds, and some of them they choose to do the anti-conceptive care and give the information for that. But yeah, most of the times when community midwives are getting exhausted, they are thinking, oh, I can work in the hospitals. Many midwives make the transfer to the hospital because there is a better work-life balance over there. But still, then I don't know, but we have to research those midwives more. We don't know if they're experiencing more conflicting values because they have to work in the hospital under supervision of the obstetric, the doctors. So we are thinking about it like social midwifery can be like an extra role. Maybe we can do something like that. I don't know what you are thinking about, because what kind of roles do you choose? You can be a researcher or a lecturer, of course, but other things, what do you do?
There really isn't a lot of choice. You know, you either are all or none. The only way you are really in Ontario doing something that is that doesn't include birth or doesn't include a portion, antenatal or postpartum, is if you are in a model of care, right, that has specifically said that this model that you're going to be in only does this, but your scope within regulation stays the same. So I'm still able to do everything, but I'm going to focus my work here. So my title doesn't actually change. And I don't know, this is a bigger question, obviously, because it involves regulation of that new role. Who is that going to be? What's that going to be about? So it may not be anything about new roles. It might just be the models we work in, right? I just thinking about that second birth attendant, or you had a term for that. I missed the title there, but of the person who is helping within the hospital.
Yeah, that's the maternity care assistant.
There, you are exactly. So that's where I was kind of just snowballing that thought. But
but we also have midwives who say, okay, I'm not. It's too easy for me now. Like I want to do more in which I can think more, and I want to have more responsibilities. And sometimes they go to be a policy maker at our Royal College of Midwives, but we don't have that many positions for women to choose. I want to do this or that, and we have to keep these bright heads because they can help us move on with our profession. So it's very hard. We are thinking about it. We are actually talking to our College of Midwives about this this topic. Yeah.
No, great. It's great work. Thank you for bringing this today.
Thank you.
It aligns with a lot of the work that many of us are doing. So
Yeah,
thank you so much.
Yeah, thank you. You're welcome.
Yeah, I think the overlap is really, I think it's very useful for us to know that we aren't alone in these questions and issues, and that there's so many similarities between, the midwifery experience in the Netherlands and the midwifery experience here in Ontario. And so I think there's lots to learn and to share from each other. So I hope this is the beginning of, many conversations. I think the well-being piece we're starting to look at with our students as well is, how do we foster that, well-being and wellness focus from the beginning so that then they might carry forward. And I know that's something that you've been thinking about as well. And the access to care issues is certainly something that other researchers in Ontario have really started to dive into also. So tons of overlap, which is great. So tell us, just before we wrap up, where are you headed next? What are the next studies on your horizon? You've told us about the values piece and the professional identity study. But what else is now that you're going to soon have a PhD, Liesbeth, what are you going to move on to next?
Tell us.
Fortunately,
We already have a new PhD, so we can move on.
We have one new researcher in our team, in our well-being team, who started with her PhD trajectory, and I am busy with the well-being 2 study. This is the 2023 study. I wanted to do several grant applications for the transition into practice support for newly qualified midwives. We were working on with Anne. So we wanted to find a collaboration with the mentoring program, and we also do some action research about transition into practice support for newly qualified midwives in several collaborations in different regions to find out what
actually works.
What actually works. So we have some experiences with what works in the Netherlands, and we are already in a collaboration with the Royal Organization of Midwives. It's a professional organization of midwives to collaborate close with them on several subjects. So they do the implementation part and we do the research part. And next to that, I am actually working as an educator in the bachelor and the master's program. So busy.
Yes, exactly.
Yeah.
Lots to juggle.
Yeah. But we were very inspired by the social justice course, Claire. So we will heading back to you because there's a lot of work to do. Development we needed in the Netherlands about these topics.
It just adds another layer to all these questions, right? Of access to the profession, those that want to provide care that are culturally specific, and it just keeps
and we also had some education we followed with you and your colleagues, and we saw that we have another population of students, and how do we access, what's the access of the students in the Netherlands, because we have not so diverse population as we wanted to.
We will connect, for sure.
Yeah, and I think I really appreciate you sharing your emails and introducing us in the slides to the other colleagues too. It'd be great to connect with them as well and to hear more about their work. So I think this is the beginning of hopefully many ongoing conversations and further.
And we have the Zoom and the online possibilities.
So it's quite easy to talk to each other now.
Yeah, exactly. That's true. Yeah. So we'll have to, if people are inspired by today or you have further questions, reach out to either folks. And thank you once again for your presentation and your time today. We really appreciate it. I can put up the flyer or poster for next speaker series. Let me do that now. So I think you are seeing, I hope, the right one.
Yes.
Okay, so please join us next month on the last Wednesday of the month over hopefully your lunch hour, 12 o'clock to 1 o'clock. So it's the 29th of November, and Oliver, one of our research coordinators, and Abby, OB resident here at McMaster, will be sharing some findings from the scoping review that they've been leading, looking at redefining reproduction and sexual health as part of our gender inclusive language project. So really excited to share some of those results with you. So hopefully you'll join us back then. And we won't have a rounds in December because I think people will have other plans on the last Wednesday of the month. Usually, there's that time off thing, holidays thing, but then we'll resume again in January. So we'll keep you posted on the January talk shortly. And we really hope you're able to join us. And thanks everybody for attending today and sharing your time with us as well and engaging in such great dialogue. Have a good rest of your Wednesday.
Thank you.
Bye-bye.
Bye-bye.